A small clip closes around a fingertip. Light passes through the thin tissue. A number appears on a screen, an estimate of arterial oxygen saturation. The patient is visibly in respiratory distress, but the number can still look reassuring. In 2020, Michael Sjoding and colleagues published a study in the New England Journal of Medicine that gave this ordinary clinical scene a disturbing edge. What is at stake is not only whether a device is accurate, but who or what medicine treats as a credible source of knowledge when the device, the clinician, and the patient do not seem to agree. A pulse-oximeter estimates arterial oxygen saturation by passing light through a fingertip, an earlobe, or another thin body part. Clinicians commonly use these readings to assess oxygenation without drawing arterial blood. This is part of the appeal. The reading is quick, it is non-invasive, it takes the form of a number, and numbers often arrive with an institutional authority that a spoken report does not possess. But a pulse oximeter does not directly measure arterial oxygen saturation. It estimates saturation from light absorption. An arterial blood measurement, by contrast, can reveal what the blood itself shows. The difference matters when the estimate appears reassuring, while arterial blood measurement reveals low arterial oxygen saturation. Sjoding and colleagues called this occult hypoxemia. Low arterial oxygen saturation hidden behind a reassuring pulse oximeter reading. The term is clinical, and its implications are philosophical. A patient can be struggling to breathe, a clinician can see that struggle, yet a device can present a number that seems to settle the matter, or at least to set the terms on which the matter will be discussed. The patient's condition becomes something that must be reconciled with the reading, rather than the reading becoming something that must be reconciled with the patient. That reversal is not always the result of bad faith. It may be a habit of credibility. We give more weight to a device because it seems objective, and less to a person because their report seems subjective. But objectivity is not a magic property carried by a machine. It depends on how the machine estimates, where it works, where it fails, and whose bodies are reflected in the conditions under which its performance is understood. This brings us to Miranda Fricker's question: what kind of wrong occurs when someone is not believed as they should be, not merely as a person in need, but as a knower? The next problem is to define that wrong without reducing it to a simple mistake about evidence. Miranda Fricker developed the concept of epistemic injustice in Epistemic Injustice, published in 2007. Epistemic injustice is a wrong done to someone in their capacity as a knower. That final phrase matters. Fricker is not only concerned with cases where someone forms a false belief. She is concerned with what happens to a person when social prejudice affects whether their words can count as knowledge. Her best-known category is testimonial injustice. This occurs when prejudice leads a hearer to give a speaker less credibility than the speaker deserves. A credibility deficit is that unjust shortfall in the credibility assigned to a person. Someone speaks, someone else assesses the testimony. Social identity prejudice shapes the assessment. The speaker is not simply disagreed with. They are heard through a distortion. Fricker's second category is hermeneutical injustice. This is a disadvantage caused by a gap in shared interpretive resources. Interpretive resources are the concepts and terms people use to understand and communicate experience. If those resources are missing, an experience may be difficult to name, explain, or even recognize clearly. Fricker uses the historical absence of a widely available concept of sexual harassment as an illustration. The point is not that harmful conduct could not occur before there was a common term for it. The point is that the absence of the term could make the experience harder to articulate and harder for others to understand. A person may have something important to communicate, yet lack the shared language that would allow that communication to travel. In a medical setting, these two forms of injustice can overlap. A patient may describe distress and receive less credibility than they deserve in a particular exchange. At the same time, the available medical framework may lack the concepts, practices, or institutional habits needed to make sense of a systematic mismatch between bodily experience and a supposedly objective reading. The strongest objection to this argument, associated with Gaile Pohlhaus Junior, will be faced later. Perhaps the problem is not merely that institutions lack the right knowledge, but that they can actively refuse knowledge that threatens their authority. For now, Fricker's distinction lets us see why a medical encounter can fail before anyone consciously decides to ignore a patient. The next problem is to show how a clinical study turns this general account into a conflict among a patient's report, a device reading, and an institutional habit. Fricker's account draws on the idea that social identity prejudice can shape credibility assessments. This need not mean that every clinician consciously holds a prejudiced belief. The point is more unsettling. Social patterns can enter judgment before judgment presents itself as prejudice. They can shape who sounds reliable, whose discomfort appears excessive, which descriptions demand further investigation, and which are quietly absorbed into the background. Testimonial injustice concerns a particular exchange. A hearer assesses a speaker's word and gives it less credibility than it deserves. In medicine, the exchange may be brief. A patient reports difficulty breathing. A clinician hears the report while also seeing a pulse-oximeter reading. The device does not literally speak, of course, yet its number enters the encounter as evidence with a peculiar status. It can appear impersonal, measurable, and free from the complications of testimony. Hermeneutical injustice concerns a broader structure. It is not limited to one person refusing another person's word. It concerns gaps in the shared tools of understanding. If clinicians, institutions, and patients lack an available framework for recognizing that a measurement may reassure differently across groups, then the mismatch can be misread. The patient's report may look like an anomaly. The device's reading may look like the stable fact. This is where the distinction becomes useful. Testimonial injustice helps us examine the immediate distribution of credibility in the room. Hermeneutical injustice helps us examine the larger setting that makes some conflicts intelligible and others obscure. One asks, was this speaker given their due? The other asks, did the shared interpretive world even provide the resources needed to understand what the speaker was trying to convey? Neither category requires the claim that instruments are inherently suspect. Instruments can provide indispensable knowledge, nor does either category require treating personal testimony as beyond assessment. The issue is the relation between sources of knowledge. A patient's report, a clinician's observation, and a device's estimate do not arrive in a vacuum. Their authority is organized by habits, concepts, and institutions. That organization becomes sharply visible in Sjoding's clinical data, where the apparent neutrality of a number meets a measurable racial difference in occult hypoxemia. Sjoding and colleagues analyzed paired pulse oximeter and arterial oxygen saturation measurements from hospital patients. The comparison was direct in a specific sense. Pulse oximetry supplied an estimate based on light absorption. Arterial measurement supplied a measure of arterial oxygen saturation. The study appeared in the New England Journal of Medicine under the title Racial Bias in Pulse Oximetry Measurement. Its finding was not simply that pulse oximeters can be imperfect. The study found occult hypoxemia in 11.7% of black patients and 3.6% of white patients in the analyzed data. In these cases, pulse oximetry indicated a reassuring oxygen saturation, while arterial blood measurement revealed low arterial oxygen saturation. Those numbers do not tell us what any individual clinician intended. They do not establish that every medical encounter involves testimonial injustice. They show something both narrower and more concrete. A device commonly used to assess oxygenation without drawing arterial blood produced reassuring readings alongside low arterial oxygen saturation at different rates for black and white patients in the analyzed data. Now return to the clinical encounter. A patient is in respiratory distress. The pulse oximeter offers reassurance. The arterial measurement, if it is taken, may reveal low arterial oxygen saturation. The patient's visible condition is no longer merely a personal report standing against a machine. It is part of a conflict in which the machine's estimate may itself require scrutiny. Fricker helps identify the moral and epistemic stakes of that conflict. If a patient's account or visible distress is discounted because a reassuring reading is treated as decisive, the patient may receive less credibility than they deserve. That is the structure of a possible testimonial injustice. But the case also reaches beyond the individual encounter. If medicine lacks adequate shared resources for recognizing how the device's apparent reassurance may be distributed unequally, then the interpretive environment itself is inadequate. That is the pressure of hermeneutical injustice. Still, there is a danger in describing the problem only as a gap. A gap can sound passive, as though institutions simply had not yet encountered a piece of information. The next problem is whether ignorance itself can be organized, protected, and actively maintained by those with greater social power. Gaile Pohlhaus Junior made precisely this challenge in 2012 in an essay titled Relational Knowing and Epistemic Injustice. Pohlhaus argues that epistemic injustice can involve willful hermeneutical ignorance by socially privileged knowers. Willful hermeneutical ignorance is an active resistance to interpretive resources that could disturb an established position of authority. This is a stronger claim than saying that people lack access to the right concepts. On the weaker picture, a shared interpretive resource is absent. Perhaps no one has yet developed it, spread it, or incorporated it into institutional practice. On Pohlhaus's picture, resources developed by marginalized people may already exist, yet dominant groups may resist them. The problem is not emptiness, it is refusal. That distinction changes how we read a medical device and the system around it. If an institution has not considered uneven performance across different skin pigmentations, it may describe the issue as an unfortunate limitation in available knowledge. But if relevant challenges are dismissed, minimized, or kept outside authoritative practice, because they unsettle established standards, then ignorance has a more active form. It becomes part of the maintenance of authority. José Medina also criticized overly individual approaches to epistemic injustice in The Epistemology of Resistance, published in 2013. Medina emphasized resistant epistemic practices through which people contest dominant ways of knowing. The importance of this emphasis is that epistemic life does not consist only of hearers assigning credibility to speakers, one exchange at a time. It also includes collective struggles over what counts as evidence, which experiences become intelligible, and whose interpretive tools enter public and institutional use. Pohlhaus and Medina do not require us to assume that every institution always acts with deliberate refusal. Their challenge is more exacting. We cannot treat structural ignorance as innocent by default. We must ask whether supposedly missing knowledge has been resisted, and whether the people most affected have had their ways of knowing treated as marginal precisely because they challenge settled authority. Applied to pulse oximetry, this objection prevents an easy resolution. It is not enough to say that a device has limitations and then move on. The next problem is how current medical oversight can redistribute credibility without abandoning instruments altogether. The United States Food and Drug Administration issued a safety communication about pulse oximeter accuracy and limitations in 2021. In 2024, the Food and Drug Administration held an advisory committee meeting focused on pulse oximeter performance across different skin pigmentations. These are concrete signs that the problem concerns not only isolated bedside judgment, but the public evaluation of a widely used medical instrument. Arterial blood gas testing provides a direct laboratory measurement used to assess arterial oxygenation. Pulse oximetry provides an estimate from light absorption. The contrast does not make the pulse oximeter useless. It makes its role a matter of judgment. A reading is evidence. It is not automatically the final court of appeal. Fricker's framework does not require rejecting instruments. It requires examining whether credibility practices are distorted by prejudice. In this case, that means examining how authority is distributed among device, clinician, patient, and laboratory measurement. It means refusing the shortcut by which a number becomes objective simply because it is numerical, while a patient becomes doubtful simply because they speak from their own body. The modern stake is concrete. When a measurement was built and validated within unequal conditions, how should medicine redistribute credibility between device, clinician, and patient? Subscribe for more philosophy grounded in the systems that shape ordinary life.